So this video is mainly to show you some examples of atypical fibroxanthomas and just to discuss the workup, because at the heart of it, an atypical fibroxanthoma is essentially a diagnosis of exclusion. They often are atypical spindle to epithelioid neoplasms on the scalp of elderly patients, but they can occur anywhere in the body. And what you'll see is a mix of spindled to epithelioid, very atypical cells usually, but not always highly atypical. And you can see scattered mitotic figures in this example. You can see that they've got a lot of nuclear pleomorphism. The background kind of grayish to amphiphilic cytoplasm here. Oftentimes they're ulcerated on the top with some acute kind of wound healing, granulation tissue with neutrophils, inflammatory crust, et cetera. But the action is in the dermis. Now, if you get under it all, you can essentially call it an AFX, but if you transect it, you're not sure if it's going to be a pleomorphic dermal sarcoma, which are typically more invasive. They've got necrosis. They go down into the sub-Q. They have a higher chance of metastasis. So if you just get a biopsy that's transected, you're going to have to essentially sign it out as atypical epithelioid neoplasm or spindled epithelioid neoplasm, see comment and say that the differential includes an AFX, but correlate with the excision specimen. So how do we exclude other diagnoses? So you'll want to do a keratin stain. You'll want to do a broad keratin stain for both high and low molecular weight, or separately, just making sure that there's no higher low molecular weight keratins being expressed. The reason why is some sarcomatoid sarcomas or keratin squamous cell spindle cell lesions can actually stain positive for keratins. And so if you do just maybe a low molecular weight, you may miss some of the high molecular weight spindle cell squames. So you definitely want to stain for keratins. I think a P63 is also very helpful, because if you find that this is diffusely positive for P63, then you're going to be thinking more of a poorly differentiated spindle cell squamous cell carcinoma, as opposed to an atypical fibroxanthoma. So definitely want to make sure that your keratins, both high and low molecular weight, as well as P63 and P40, are negative. Next, you'll want to do melanocytic stains. So you'll want to make sure that this is not some type of spindled melanoma. So you'll do a SOX10. You could do a melanA. I like SOX10 because it highlights the nucleus. It's a little bit cleaner. And it captures any atypical neural neoplasms as well. So if SOX10 is negative, then you've excluded melanoma. You might see that some of these have small kind of vesicles within the cytoplasm. So make sure you're not dealing with some type of smooth muscle. So I would do, SMA can be positive in AFXs. So I would definitely think about doing a Desmin. Usually AFXs are not going to be significantly positive for Desmin. And once you've excluded your smooth muscle, your squamous cell, and your melanoma, you could also think about excluding an angiosarcoma, because you can definitely have this type of pattern with this vascularization and atypical epithelioid to spindle cells on the scalp of somebody, for example. So make sure you exclude an angiosarcoma by doing a CD34 or an ERG stain. ERG is kind of more preferred across various practitioners. So once you do all that and it's negative, you can pretty much sign it out, as I said, with that atypical spindle to epithelioid neoplasm, see comment, AFX fits, but also you'll want to correlate with the excision specimen. And this second example is just to show you that not all of the atypical fibroxanthomas have as much nuclear pleomorphism in an atypia. So here, I would say that you definitely appreciate the spindled cells, and some of them are atypical, but there's not as many mitotic figures in this specimen. But on immunohistochemistry, it pretty much checked out to be none of the other diagnoses we discussed. So again, it's hard to say on H&E. And so you need to understand that there's a workup involved. And if you get a digital slide like this, they would probably just tell you it's negative for all of those other markers, and then you would be able to choose atypical fibroxanthoma. And remember, if it goes down deep into the subQ and you see invasion and necrosis, you can think about pleomorphic dermal sarcoma.